Sir, we can start, sir.
Today, we thought we'll discuss about intussusception in infants and children. So, intussusception is a common topic. You might be wondering why in neonatology topic actually we are talking about intussusception. So, intussusception can happen in neonatal age as well. And most important is weaning is completely done most often by the primary neonatologist who takes care of the baby. So intussusception is a common topic which is very important for most of all the neonatologists. So in this, the most important part is weaning. The second important part is most important is prevention, and which is completely in the parents and the neonatologist's hands. And the management overall, actually how things are changing over decades. So when I was doing my post graduation, we invariably we used to do laparotomy. So, but nowadays actually many people are not going for laparotomy. So we'll discuss about all these things in detail. I am Nagendhar, pediatric surgeon, chief consultant pediatric surgeon from KIMS Cuddles, Hyderabad, and we are managing a team, and we'll be covering all the Cuddles hospitals in Hyderabad. So with this brief introduction, I will go into the topics of the intussusception. So basically, what is intussusception? All of us know it is the distal into the distal segment. The proximal segment is going for whatever might be the reason. So we'll talk about the reasons. So and very rare, of course, in intussusception coming or seen in neonatal period, but only once in lifetime, actually, any surgeon or any doctor may see one patient at least is a possibility. So, especially the reason being, actually, it might be because of some lead point. So, in KIMS Secunderabad, actually, Cuddles Secunderabad, actually, we saw one patient actually who just crossed the neonatal period. Actually, it is whenever actually neonatal period comes, actually, then we'll think that maybe a lead point is there. So if lead point is there, definitely lead point needs to be tackled. So hydrostatic reduction, conservative management, all these things won't work out at all. So the most common age group which we see often is when really weaning starts. So sometimes actually, as doctors, we are also forced to start weaning early, or sometimes it happens that weaning is started early by the parents, over enthusiastic parents, to try to beget a maybe healthy or bulky child. So this happens in the overzealous families, and often it is because of actually most often period is actually 6 months to 3 years of age. This is the most common period when we see intussusception. So and often around significant portion of the people we see it less than 2 years of age, and male to female ratio is statistical, but it is not that much of importance. And most commonly what we see is ileocolic intussusception, and 90% of the reason is idiopathic, which is mainly because of the hypertrophied Peyer's patches. It is which happens in some infective process, or during the weaning process also sometimes it will happen. So other than that, actually there are some lead points actually which are Peyer's patches, something like Meckel's diverticulitis when edema comes. That is also a reason, and tumors and polyps and lipoma or a hemangioma of the small bowel. All these things can be reasons as lead points. So coming to the intussusception, there's a typical cycle. My professor used to tell, "Bacha rota hai, sota hai." So there will be a continuous cycle. Like he'll be continuously crying whenever the colicky pain increases, and after some time, actually, he's so tired that he sleep off, and then actually just that crampy pains will wake the child up, and that will force the child to cry again. So as the time increases, actually because of the intussusception, when the tightness increases and the pressure is increasing, so that is what we call as a diabetes, actually where the blood cells actually will start coming out of the mucosa, and that will add to the mucus which is secreted by the goblet cells. Together it will form what we call it as a typical current jelly stools. So it's not necessary that every patient will have current jelly stools. But current jelly stools occurrence itself says it is slightly late presentation. So and that is because actually that means actually edema is so significant that it is leading to problems. So most important is the clinical suspicion. If the surgeon or pediatrician, neonatologist, if we think yes, it is intussusception, yes, actually that's better to evaluate the patient. And usually these are the children already they are having some recent history of meeting a doctor because actually the child is having either a cold or a cough, which is the viral etiology, which will lead to increased size of the Peyer's patches or thickened Peyer's patches. So as usual, actually all of us actually will try to evaluate, and then ultrasound or X-ray abdomen will be done according to the problems of the child. So intussusception is where actually the one colon is going into the other colon. So this telescoping usually happens from the thickened ileum. Initially, it will start as ileo-ileal, and later actually it will start going into the ileo-ileocolic or ileocolic or ileocolocolic or whatever combination it might be. So this is how a typical intussusception process starts. So it's usually a progressive course, actually, where intermittent abdominal pain, actually, just now we spoke about the crying and sleeping cycle. And as the time increases, it will go into vomitings, and then what we call it as a blood current jelly stools, and there will be lethargy as well. And typically, you will be able to find actually kidney shaped swellings, which will be more towards the umbilicus. The curvature actually will be more towards the umbilicus. So as it is starting from the right iliac fossa, and it will start going up into the uh, right hypochondrium. So whenever a radiologist or someone says, actually, or a mother says, I am able to see a mass in the uh, right upper quadrant, that itself clinically clinches to the our diagnosis that it might be a case of intussusception. Sometimes there can be multiple as well. So that typical triad is there, but it's not seen in all the cases. That is that abdominal pain will be there, vomiting can be there, and recurrent jelly stools can be there. So, but most of the people like they present with cranky, colicky abdominal pain, which is the most common cause. And intervals can vary. Actually, initially they'll start with smaller intervals, and as intensity starts increasing, the intervals will keep on increasing. So, an inconsolable child comes to our or your OP or our OP. Actually, it's means it might be a case of intussusception, especially taking this age into consideration. And of course, pain itself, colicky pain itself can lead to vomitings, and sometimes it can be because of the intestinal obstruction component, which is adding on to that. So the typical next, I will come into the investigations later. So coming to the diagnosis, actually, I was talking about actually physical examination is the most important thing. And if the right iliac fossa is empty, and if the mass has gone into the right upper quadrant, that is what we call it as a signy dance. If this is there, then it is okay, that's what by physical examination itself we'll be able to tell. So at least mother can tell, mother or us actually we can examine during that interval period of uh, free time, actually when the baby is sleeping. So there is no point in examining a child actually when the baby is crying crankily and with absolute actually tight abdomen. They cannot predict or you cannot guess what is what. So next investigation, usually what we go for is actually ultrasound. Ultrasound typically shows actually a sandwich sign, actually pseudo kidney sign, whatever it is. And when the degree of the doubt is more, actually we can sometimes go for barium enema. But in this 20 years, actually, I have never seen, as a pediatric surgeon, I have never seen anyone going for barium enema. Means actually, it has become a little bit obsolete nowadays. But when we were doing actually MCH and all, that time actually we used to have barium enema is as one of the important diagnostic tool. So that is more of for examination oriented knowledge or some other knowledge, but barium is now no more useful tool or used at all. So in short, actually, I made this slide actually so that actually all of them actually this is how actually a typical management of interception goes after the evaluation. Actually, we'll go for edema. Actually, we were talking about actually it can be diagnostic or therapeutic. There are many signs actually are associated with it, actually coil spring appearance or meniscus sign or claw sign. All these signs, but there are more of now armamentarium only for examination questions or something like that. But clinically, it is not useful nowadays. And so the surgery, when you call for a pediatric surgeon, actually, what we do is actually we literally prepare the child for a laparotomy. That is most important. That is the first thing actually all of us should understand. Any case of suspected intussusception after diagnosis, he needs to be prepared for a surgery. Doesn't mean that actually a surgeon is going to take the child for surgery. But actually he should be prepared for a surgery. And we'll talk about it later. So there are various types of hydrostatic reductions. We can use either air, we can use barium, or we can use saline. So whichever means. So to that, we are going to add either X-ray or CM or ultrasound. So one of these three things. So radiologist is a very important person in the management of intussusception apart from a pediatric surgeon. So uh, we enthusiastically we used to do actually barium enema when I'm talking about 20-25 years back. So but nowadays it is not used because if once barium perforates and if it goes into the free peritoneal cavity, it is going to lead to barium peritonitis, and it is almost 35 to 50% mortality risk is there. Even if it is not there, actually the additions will be so bad that actually lifelong morbidity will be there for this patient. That's why barium lost its barium enema as in the diagnosis or management lost its value. And the hydrostatic reduction is one of the beautiful tool actually which all the pediatricians have in their hands. So, but the only drawback with the hydrostatic reduction is 5 to 10%, we can call it 10% high chances of recurrence will be there. So it will be more in the first 24 hours and slightly it will reduce, but actually it is more significantly around 95% of them actually will happen if at all if they want to happen in the first 48 hours. But that is partially because of the parents or the primary doctor itself. Because sometimes actually some parents will pester us. Actually, no, doctor, actually my baby is crying too much. Since 2 days I did not give anything. Shall I give something? So that time, if you try to give actually show a little bit of mercy on that child or the parents, definitely he'll have recurrence. So as a strict policy, let the edema subside. It is going to take some time. To some extent, some people give steroids also actually to reduce the edema in the bowel. So uh, so always actually try to keep the NBM status very strict. And again, I was telling actually barium lost significance, and always prepare a child for surgery. I meant by preparing surgery means actually pediatric surgeon is well informed that actually he should be available for laparotomy also if necessary, and he should actually get the viral markers, all the evaluation, electrolytes, because he has been vomiting for the past so many times. So his hydration, his shock, actually his hypovolemia, everything should be corrected actually before all these things are planned. And anesthetist, PAC, pre-anesthetic checkup should be done. And anesthesia and operation theater should be informed. We should tell them that this child from the radiology suite, and maybe I'll get directly to operation theater. The idea being, sometimes it happens that actually it while doing the procedure itself, it can perforate. So we are not very sure actually if I have perforated or not. So of course, actually radiologist will tell actually even the X-rays if I am using, that will tell. So hydrostatic reduction is the most beautiful tool in the management of intussusception. The main idea is actually even a surgeon actually, though we are surgeons actually we feel very happy if I am able to give the same result without putting a cut without cutting the abdomen of a small, tiny, tender, soft abdomens. So similar result I am able to give by doing a simple hydrostatic reduction that gives immense pleasure to the family and the surgeon as well. If hydrostatically, if you can reduce it. So we discussed again actually same thing repetition, but air, if we are using actually we'll be using actually it will be attached to a sphygmomanometer and we'll be monitoring the pressure, and then it is done under the fluoroscopic guidance. So I air problem is actually too much of radiation is there. So that's why actually many people they don't prefer, or if a radiologist is not available during that time of the hour, maybe yes, actually pneumatic hydrostatic reduction has got its own value. It is a beautiful technique, and the advantage being the air, even if it perforates, only the air has gone out of the intestines. So it is not a big disaster. It's something like a simple perforation without anything going into the free peritoneal cavity. So air still has got its own thing. So I want to share one of my experiences with air pneumatic reduction. I was busy taking care of the cranky, crying baby with minimal support, because into the radiology suite, actually, some sisters may not come because actually they're in the family period. Actually, they want to conceive or some for some reason. So literally, your support will be very less. So in these situations, actually, when we am concentrating on the baby, so once it happened that we have the sphygmomanometer connection, actually something. I suddenly noticed that the abdominal pressure was so tight, and the baby is crying, abdominal pressure is also adding on to it. So the abdominal pressure has gone so high. Actually, I could see that actually literally the lower limbs have become a little bit dusty. So that means you understood actually the child was going into a high intra-abdominal pressure, which is turning into intra-abdominal hypertension. And if I have not noticed, or if we are not very alert, so there is a possibility that these children can go into abdominal compartment syndrome. So beware of this, and so always I on that sphygmomanometer is very 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 important during a hydrostatic reduction. So that's why air pneumatic reduction has got its own little bit of drawbacks, but it's a lovely technique. And the other thing is selling ultrasound guided hydrostatic reduction. So this is a beautiful tool, and where you don't require any type of literally significant radiations, and radiologists are available in most of the city hospitals round the clock. Even a junior or a senior, and can help us with reduction of uh, uh, intussusception. So baby is well prepared, baby is hydrated well, and his electrolytes are corrected, his hydration is given, and then actually we'll arrange everything in the radiology suite, and then actually we'll take all the required equipment for the hydrostatic reduction, and then we'll be performing this hydrostatic reduction. So we'll talk about it in the coming slides. And suppose actually what happens, I may be able to reduce, I may not be able to reduce. If I am not able to reduce, at least one beauty or advantage of this trial is I have reduced it significantly to such an extent that my surgery, or be it laparoscopy, open, whatever it is going to be very easy. So bottom line is, not every intussusception can be reduced significantly by hydrostatic reduction alone, because only if it is coming in the early period, it will be successful. If they come very late or from very remote area with absolutely obstructions, so all these conditions actually we may not be able to give a 100% result. Yes, but still we can give an 80 to 90% of the result. So that's what actually I was talking about, laparoscopic assisted hydrostatic reduction. So some people actually they do laparoscopic assisted hydrostatic reduction, but it is not much preferred because ultrasound can do the similar work. So that's why laparoscopic assisted hydrostatic reduction is not that popular and not that advised. So the other thing is just doing a simple laparoscopic reduction. So after reducing it significantly by doing a hydrostatic reduction, so we have come up to a small size, maybe in the right or just below the right hypochondrium. It's only a small segment. So that small segment is really tight. Yes, in that actually with little bit more force actually applied by doing a laparoscopic reduction. Laparoscopy again advantage is actually they are giving minimal scars possible on the baby's tummy. Yes, surgery is sometimes still indicated because sometimes actually uh, the amount of the damage or associated gangrene or associated intestinal obstruction, it obscures the abdomen completely, that we don't have any space in the tummy to put any scopes. So again, I was talking about actually abdominal compartment syndrome. So already distended bowel. Over that, actually, I am feeling the new creating a new operative in the laparoscopy. These two will definitely add to increase intra-abdominal pressure, and sometimes these people can go into and already it is a well hydrated baby. Too much of fluid hydrations also can add to all third phase losses also. So from all these points of view, actually, you have to keep in the mind is, am I pushing this baby into some intra-abdominal hypertension, or am I pushing this baby into abdominal compartment syndrome? So I'm insisting these because actually these are all treatable problems. So treatable problems should never be iatrogenic, and treatable problems should or preventable problems should never go up to the treatment. So we discussed about the recurrence rates is around actually 5 to 10%. Actually, in hydrostatic it is 10%. In operative procedures, it is around 5%. But still possibility of recurrence is there. So in Cuddles, actually, as a norm, actually, we started this institutional practice of doing hydrostatic saline reduction. Though various types are there, we don't prefer all those things. We go for hydrostatic saline reduction. That is a rule of we follow in this actually rule of three. Actually, we keep it at 3 feet height. Actually, as a normal saline bottle, which will be kept at 3 feet height. 3 feet height is almost like 100 centimeters. 100 centimeters of water. So if 100 centimeters pressure is allowed, and each time actually we give a trial of 3 minutes only, ideally, and like this actually we can give a trial of 3 items. So we'll try to give a hydrostatic reduction for 3 minutes, and then we'll wait, and after some time, after the baby is ready to cope up again, and then we'll give again a second item, again a third item. So if after the 3 items are given, actually if at all if it is not getting reduced, that means actually it is a delayed presentation, it is not getting reduced. Edema at the ileocecal junction is so tight, it is not allowing the bowel to come back, or even if it goes into gangrene, actually, or if the associated lead point is there, which is bigger. So these are the conditions actually where actually we'll call it as a failure. So then we'll call it off, and then as I told, actually my operation theater is ready. So I'm going to literally rush the child from here to operation theater. So there we'll decide actually whether we are going to do a laparoscopy or whether we have to do a open surgery. So keeping everything ready is very important in this procedure. So we should not we should mentally prepare. Actually, consent should be taken for hydrostatic reduction as well as laparoscopy or laparoscopy. So if necessary, actually hemoglobin is less, blood need to be arranged, and like that. So hydrostatic reduction, actually, these are some of the pictures how they look like, and during the end of the procedure, and after the end of the procedure, on the right side, you are seeing actually that thickened ileocecal valves actually will be seen across which actually the intestine has got reduced. So this is how actually a typical reduction actually looks like, and sorry for the video. So actually audio is not coming, but actually you can see baby is continuously crying when I am doing a hydrostatic reduction. So this is how typically a hydrostatic reduction procedure goes on, and the baby should be awake. So some people actually they try to sedate the baby, but we want an active child who's crying like that. So and that will add to the intra-abdominal pressure. That will add to the pushing of the help. It helps in the hydrostatic reduction. So this is how actually we do. And in the on the right side, actually, you're seeing a baby who's really comfortable. He's comfortably sleeping, actually, even after the procedure is over. This is how exactly the baby looks before the procedure and after the procedure. So, what are the endpoints of successful hydrostatic reduction? Are one, ultrasound finding. Radiologist will tell, yes, I have reduced it. Actually, yes, fluid went in the small bowel, and small bowel fills. So, for even for lay people, actually, we will be able to understand even with less of radiological knowledge, we'll be able to understand that small bowel, central small bowel is filled. That itself says that hydrostatic reduction is done successfully. And like how you saw, actually, the child will be so comfortable after the procedure is done. And you can see that immense satisfaction because actually, as surgeon, we know that it is going to get reduced. So we already have that happiness in our hearts. So, but radiologist also will feel very, very happy because so after everything, if you are giving a successful result to a family without cutting, without doing any major uh, big procedure, if you are able to do it, it gives immense pleasure. So that's why, as pediatric surgeons, we are proponents of hydrostatic reduction for intussusception. We already discussed some of the facts, but some facts should be known to all of you. One is, again, I'm insisting, operation theater should be ready. So without actually screening, don't take the child for hydrostatic erection because after the procedure is over, actually a parent's expectation will be answer either yes, actually it is reduced, or yes, I am going to ship the child to the operation theater because after that they won't give much of time for us. So the other thing is 10% recurrence is there after hydrostatic erection. So don't budge to the family concerns of my child is crying, my child is cranky. So don't do that. Don't give anything to them. Other thing is usually at least hydrostatic erection we do it any we can do it any number of times. Times means which comes actually interceptions can come actually at any point of time. So if it comes also actually we'll be doing it actually after I'll share one of my clinical experience. You'll understand. Even after second or third experience, actually a third time, actually hydrostatic reduction is done. Then keep it in mind something else is a problem that child may require surgery because we have to rule out a pathological lead point. And after surgery, also actually there is a possibility of 5% difference. Actually, we discussed. And sometimes it happens that actually after any surgery, because of hyperperistaltic movements, actually there can be associated post-operative actually intussusception, which usually subsides by its own. So this is one of the clinical presentation actually one of the case I have seen. So I did hydrostatic reduction actually a long time back and successful hydrostatic reduction. Parents are very happy. And after 6 months, like, he came back again with one more intussusception. Maybe because actually they can pay us back something. Yes, actually we did hydrostatic reduction again successfully, and the parents are happy, child is happy, and now actually the patient came again after 6 months, some period. Usually, as all of you know, actually it comes in two seasonal episodes. Actually, whenever we get more of adenovirus or rhinovirus infections. So after 6 months, when the child came again, the ultrasound showed ileocecal intussusception. Then we had various options in our heads. So one is it should I go in for hydrostatic reduction? The parents are so happy with me. If I tell them, let's do a hydrostatic reduction, they know my success rate. Definitely, they'll tell, yes, go for hydrostatic reduction. But should I give that option? I said no. And especially, I was talking about actually number of attempts. Actually, when 2 or 3 times actually hydrostatic reduction is done, so then preferably we should not go for one more hydrostatic reduction. So we should start thinking: is there any lead point? Is there any other reason why it is happening like that? So, and age preference also. Actually, if the child is up to 2 or 3 years, actually, we can do this. I think of doing hydrostatic erection. But after 2 or 3, 2.5 or 3 years age, that idiopathic reason for hydrostatic intussusception is not a possibility. That's why hydrostatic erection should not be done beyond 3 years of age group. So this point, actually, all of us should understand, and there is no point in giving that option to the family, because once you give an option, actually, they start catching you for everything. So coming to the open laparoscopy, that is individual preference, actually according to the institute preference and what is available. So usually, actually, in KIMS Cuddles, we have actually all the facilities. So we give first, actually, the option of hydrostatic, then laparoscopy. And coming to should I do appendectomy in all patients of intussusception when we operate? So once upon a time, yes, actually a few decades ago, yes, appendix needs to be removed actually in all cases of intussusception surgeries. But nowadays, actually, appendix is supposed to be not no more a vestigial organ for a pediatric surgeon. For us, actually, we use appendix for many things. Something like we use it as a replacement for the bile duct. We use it as a replacement for urethra. We use it as a replacement for ureter, and we use it in the replacement of to augment the bladder. Actually, we use it as a catheterizable channel for Malone's continent procedure, or sometimes actually in urogenic bladders we do actually bladder augmentations. As the catheterizable tube, actually we use appendix. So appendix is not vestigial anymore. So removal of appendix is not going to help in any way. So recurrent intussusception, yes, actually, most of the people what they tell is don't wait for the fourth one, and by third episode itself, after two hydrostatic erection, third episode itself, you have to go for surgery or some procedure. So this is one of the cases actually that we have done laparoscopically, where because of this that I was talking about the same child. So for this child, actually, what we do is actually ileocecopexy. Actually, so if this is the cecum and this is the ileum, so it is they're going at this angle, so it is going easily into this one. So what we try to do is we try to make it a acute angle, and then we'll not allow it to uh, go into that actually by fixing both the things. Actually, by fixing the ileum to the cecum. So this is what is called ileocecopexy, where we put actually 2 or 3 non-absorbable sutures so that the angle is fixed like that. And because if this is not able to go, it is not going to go at all. So this is how we can prevent a recurrent episodes. And same time in the laparoscopy, we'll be able to see if there is any lead point in as a reason for the intussusception. So quite often, actually, whenever actually GE season comes, actually all the pediatricians will definitely see similar reports in their clinic. Patients will come with similar reports. They'll tell lymphadenitis and mesenteric lymphadenitis. Along with that, actually, intussusception is there. So we get many false calls telling that as pediatricians, we get many false calls telling that intussusception needs to be operated. So I'm just actually uh, trying to just educate, especially the younger generation. So the word intussusception doesn't mean that actually it needs surgery or it needs a procedure. So intussusception, if it is a small bowel to small bowel, that is what we call it as a transient intussusceptions. These are the conditions where actually we need not panic, we need not operate. So or do anything, just manage conservatively. So easiest conservative management is giving some sort of bowel rest. The some sort of bowel rest is either give the baby NBM or give only ORS or plain water or coconut water. That is going to take care of that actually, because by the time it goes into the crawl stomach and goes into the duodenum or early small bowel itself, it gets digested. So there is no need for intestinal peristalsis to enhance. There is no way actually edema, bowel edema increases. So transient intussusceptions are commonly seen in your day-to-day practice in any colicky abdominal pain. Transient intussusceptions are possible. So one clinching diagnosis for this is if the intussusception size itself is very small. Usually, I ask the radiologist, what is the diameter of the intussusception? So usually if he says it is less than 3.5 centimeters, I consider it as a small bowel intussusception. So it is going to be transient. It can be seen in some scans. If the patient's luck is different, he will see both scans. He'll find a small bowel intussusception. It doesn't mean that actually we have to go in for surgery. So transient intussusception, actually, we are just simple bowelless is enough. So we discussed about what are the various types of hydrostatic reductions that we do. And so last something like I attended one of this rotavirus intussusception study as well. In that study, actually, the tetravalent was the vaccine is the one which led to intussusceptions. That's what they call. But whatever it is, viral load vaccination, viral load can lead to intussusception. That is a theoretical possibility because viral loads can enhance Peyer's patches, which are lymphoid tissues. Actually, that's why thickening of the Peyer's patches can lead to intussusception. So that is a possibility. So that's when they came up with the pentavalent vaccine. So rotavirus is attributed actually maybe because it's a recent one. And coming to barium enema, actually, I told about actually the various types of signs are there. So the first one, actually, what we call it as a meniscus sign. The later, actually, claw sign, actually, where it will look like a claw, and then sometimes actually maybe if you see his claw is associated with little bit of coil spring appearance is there in the middle picture, and then when we are attempting a barium reduction, this is how actually we are going to see where the central small bowel will be filled with contrast. So, but luckily or unfortunately, barium enema has lost its value. It's good for us. So, barium reduction is no more considered. So, the decision making in a case of intussusception is very important. If a child comes with a clinical presentation like this, where multiple atrial levels are there, and if you can see right atrial fossa, actually it is literally empty because the problem started with that at that point. Actually, you won't see much of atrial levels in that area. So, if the patient presents with actually multiple atrial levels like this, it is a case of interstitial obstruction. The first thing actually you should do is hydrate the baby, actually take care of the dehydration, take care of the electrolytes, stabilize the baby. Only then shift the patient to the for anything. So without that, actually, if anything is done in that excessive stress and crying, actually, baby will collapse in the radiologist ward itself, which can be disastrous for the full practice and hospital. So, so when typical intestinal obstruction is there, then maybe actually we can give an option of managing this patient. This time actually if it's so many of dilated loops, we try not to give an option of laparoscopy also because laparoscopy will make the vision very much impaired. So we can't do a proper job. So that's why actually laparoscopy option is usually avoided in a case of intestinal obstruction because we can't create so much of pneumoperitoneum. And beyond some limit, actually, if I try to give more pneumoperitoneum, I may be facing with the intra-abdominal hypertension problems. So during this laparotomy, actually manual reduction, there are many methods actually. Cope's method. Sometimes what we do is actually between this intussusceptum and insertion, actually we'll try to put the finger and then we try to release little bit of adhesion site. This is what is called Cope's maneuver. So we try to do many types of maneuvers and then we'll try to deliver it. And after delivery, actually we'll see if the intussusceptum which has gone inside, actually, is it viable or not. If it is not viable, then we'll go for resection anastomosis. So, and while doing resection, actually, we invariably see if there is any lead point because it doesn't mean that idiopathic age group lead point should not be there. They can be there. So idiopathic age group as well, actually, lead points also can be there. So sometimes, actually, I told you about failed hydrostatic reduction. So failed hydrostatic reduction actually doesn't mean that actually it is failed, but it has helped us in reducing the overall mass from a big mass. So you'll be surprised if I tell you actually, I have seen a child with intussusception which has almost come up to the rectum. Just maybe if I had not touched that patient, actually, maybe in hours, actually, I would have seen the intussusceptum coming into the rectum, per anus also. So those from that position to bringing to the right eye fossa, it is a real boon for the surgeon, because the more is interception, the more will be the cut. So as nowadays, actually, for all the surgeons, actually, if you see, it has become a fancy for all surgeons to make minimal cuts. So that is how actually minimal invasive surgery came into vogue. So because it is a pleasure for a surgeon actually to give a smaller incision as compared to a large incision lifelong. So that way I am reducing the size of the swelling, and literally actually when I do a laparotomy, I don't try to put the full hand also inside the tummy. I try to put actually one finger inside the abdomen and one finger will be all the my hand will be outside, and I'll be trying to reduce it. So with literally one or two fingers inside. So that's what a surgeon gets a kick out of. So sometimes actually they require a resection osmosis also if it is very much delayed. So the early diagnosis, early management is the key to give a better result or a scarless treatment for a newborn, for a child. So in this, actually, I was talking about actually one of my slides got missed. Careful weaning is very important. Actually, here I'll try to take some time of yours, actually, which you are very much well versed. But as a pediatric surgeon, what I talk about actually weaning, I want to tell. So usually I tell most of the families actually, yes, actually I follow your rule of till 6 months, don't give uh, any top weights. After 6 months, actually, I'll tell them weekly once to start add one item. So preferably, I'm totally against actually any of this artificial products of Cerelac, all these things and all. So I tell them actually homemade, God's given items, and one item at a time. See, because I personally feel Cerelac is a combination, or some foods are combination of many items. Like, yes, you've got milk, it has got sugar, it has got some old dried fruit or rice or something. It is a combination of everything. Uh, so ideally, we should try to stick to one item at a time, and the slowly start with 1 spoon, next day 2 spoons, next day 3 spoons, like that. Slowly increase over 1 week the same product, same one item, and then next week actually we'll start with a different product. So I tell them actually make a chart of every week, actually monthly chart, and then each month actually they'll be giving actually these types of products. Something like one vegetable, one fruit, one green leaves, and one cereal or pulses or any type. So in a month, actually, they will be able to add only 4 items. But most of the products actually, usually most of the families actually they'll tell actually we have a typical ugu at home. Actually, we prepared a homemade ugu. At least that will be a combination of some thousand items in that. So that is also ideally not correct. So a careful weaning is very important, and I always tell them actually, suppose in the process of weaning, if the suddenly child is crying too much cranky, or if there is associated actually cold or cough, and I'll tell them actually just go back by one more week. So literally, they should have a yearly planner with every month what I'm going to give. So which type of home food I'm going to give. So all these things are there. So weaning is very important, and you are the people actually who will be doing actually this weaning advice. So this is very important, because weaning is the only one actually, that's the only way you can prevent a interception from coming or progressing. So the other thing is you know, a pediatrician or neonatologist can easily suspect this child is going to have a thickened Peyer's patches because of this insult. So that I'm sure actually all of you know that this patient will develop a interception. So you are the people actually who can prevent a interception as well. So, but next coming to that, if once intussusception is done, decide between actually is it a transient intussusception or is it a typical ILO to small bowel to large bowel per intussusception. Those are the things which will never resolve spontaneously. So you have to decide. It's in your hands. And after that, actually, non-operative plans actually we have to do for all patients. And wherever ultrasound facility is available, wherever pediatric surgery is available, and wherever the radiologist is available, yes, actually give the option of non-operative plan for the child, which is hydrostatic saline reduction, which is a wonderful tool. And if that fails, yes, we have actually a minimal invasive surgery of laparoscopy that will prevent, and that will reduce. But the bottom line for all these things is prevent intussusception, and it is completely in the neonatologist or actually or a pediatrician who's taking care of the baby, especially during the weaning period. The prevention is the bottom line. It's a beautiful thing if someone can prevent intussusception. That's a boon. That means you're preventing a disease means it's like a vaccine only. So still comes in neonatology period. So always think twice before making any decision, and that's why actually we formed a team of 4 pediatric surgeons, and always actually whenever actually anything actually which needs little bit of thought process, all of us will keep discussing about these things and how to do, and what best can we do. This is what is our goal. So intussusception is a preventable problem. This is what is the bottom line I want to tell. And even if you cannot prevent, if it is progressing, so if it is going out of your hands, then the option is hydrostatic saline reduction, which is a wonderful armamentarium in pediatric surgeon's hands. Thank you for interesting topic of intussusception. We'll keep continuing to do this KIMS Cuddles one, and which is an initiative of Cuddles team from KIMS Kondapur, Dr. Aparna, and we'll do a lovely job. If anyone has got any doubts, actually we can discuss. Yeah, here we'll close the session. Thank you very much.